This episode of the Berry Chronicles is proudly brought to you by Bariatric Support Australia.
The public-private thing, very different from a practitioner point of view. I think in private, the system is so much more responsive, and so that comes with its own joys in terms of what you can do, and you can really wrap care around people. Public's a bit different, but within the constraints that you've got, that's almost a challenge in itself. It's a problem to overcome, and I think that's exciting. And then also what you do in private, you're setting up a practice and you're setting up systems of care, or you're joining systems of care. But in public, when you are working, you're often shifting policies and protocols and doing things that are going to go far beyond what you're actually doing. And then the biggest example of that's in teaching, because that's, I think that's probably the main thing that will probably keep me always in public health, is when you're teaching, when you're training people to do surgery, you imagine that ripple effect. You're like, this operation, yes, it's benefiting the patient on the table right now, but then if I can turn this registrar into an effective surgeon and the fellow that's with me into an effective teacher, then I'm contributing far beyond my normal scope. And I think that's it. And then in particular with obesity care, it's so poorly done and the access is so terrible in public that you get to stand. It's very easy to suddenly end up at the top of the peak in one of, our humble little service here in the context of Australian public healthcare is an elite unit in regards to the amount of work it does and how it does it and the efficiency of that, and not just the case numbers, but the impact we have on education and having fellows here and teaching registrars how to do this. That matters much more than I think it could. That brings a level of that's much more fulfilling than not doing that. So I think that's the bit that it's cool. It's really cool. And the really thing, like the obesity thing, is really cool because there's this aha moment you get to see where most of us come out of medical school with exactly the same idea of obesity as we entered medical school with, which should be a red flag, because every other disease you come out with a completely different understanding, but you sort of come out of a medical school thinking about obesity pretty much in the same way as you entered. And then if you end up in a centre that doesn't do evidence-based obesity treatment, that can be quite perpetuated. And that was the case for me when I first came out. And you sort of end up in this cycle of giving advice, thinking that advice is important and helpful and impactful on the disease, which it's kind of not. And you set these realistic goals for people based around diet and lifestyle that are just unattainable, just unattainable within the evidence of what we know diet and lifestyle can do. And so then it's unrewarding for the patient because they don't get a significant impactful treatment that actually changes their disease profile. And it's unrewarding for the clinician because it's not fun not being good at treating disease. It's really miserable. And so you end up in this cycle, and then you see med students, interns, registrars come and work with us, and they see something very different. And that is, we set realistic goals around what we know can be achieved. So we don't overpromise ever. In fact, we often underpromise, overdeliver. We set goals around binary outcomes. Do you have diabetes or not? Let's try and not have diabetes next year. Can you get out of the chair or not? Let's just get out of that chair next year. Really binary outcomes that are just achievements that are there and people can take on forever. And then we just go and do them because we use an intervention that is up to the task. Maybe surgery, maybe medications, maybe both, maybe neither. But we match our goals to our interventions. And so when you see that kind of success, it's really cool. And then when you explain that to people, it's sort of, the penny drops very quickly because it's pretty simple. It's what we do with every other disease in medicine. It's basic medicine, and it's kind of logic as much as it's actually medicine, right? It's just, but because of the myths that still run through society and through medicine, we're trapped out of that. Like we do things about obesity that we don't do with other diseases, and then we look confused when we don't get good results. Like, does that make, like if we were to do that in cancer care, we would be ridiculous,
It makes sense. And it's so refreshing and so lovely to hear somebody that's as qualified as you are, as learned as you are, speaking like this, because from our perspective, when you lived your life as a very big person, right? I was over 150 kilos. And I've been on the receiving end of all of those typical stereotypes when it comes to healthcare. Like, just diet, gonna fix you.
Just got to try harder. Just got to try harder. Yeah.
Just maybe exercise a bit more. And it finally, for me, it was. I actually went to a doctor after I had failed my men, and
Even that word failure,
yeah.
right?
Well,
Like,
yeah, okay.
Do you know what I mean?
Yeah.
Like if I did an esophagectomy for you to remove a tumor and a cancer, and that cancer came back, it's not a failed esophagectomy. Does that make sense? Like it's the disease. We have a progressive relapsing disease that comes back, and even that. Sorry to pick, and I interrupted and picked you up on that, but we wouldn't do that with other diseases, with other conditions. We wouldn't just be like, oh, you failed. And particularly when we talk about it, and often that failure thing is about the patient rather than the operation, which is even worse. Like that to me is even worse. Oh, the patient failed surgery.
That's definitely.
Are you kidding me? Like you can't. How do you fail a surgery? It's not a test.
That's 100% how I felt. But I went into a doctor's appointment with my GP. I saw a different GP, not my usual one. And he just looked at me and he said, you have less than 1% chance of keeping your weight off without some sort of surgical intervention. That's just me being honest with you. And I was really, really offended. It's like, no, because this is a moral failure on my behalf. This is, all of the things. So I need to fix all of those things before I'm even worthy to even consider a surgical intervention. So I was irrationally angry with him to suggest surgery, which probably sounds crazy. But years later, I went back to see him and I just thanked him because he was the one that planted the seed for me to go on and eventually have gastric bypass. And he wasn't rude, he wasn't judgmental, he wasn't any of those things. He was younger, he was just kind, and I wasn't used to it.
And he was just reading you the evidence, wasn't he? He was just saying, look, this paper, we've got decades of evidence now that says that when we do these things, these are the outcomes, and that's it. And it doesn't mean that any of those things lose value. I think that's probably the other thing that you want to be very clear on. Changing our diet, move to more plant-based, high fiber diet, move away from animal fats to plant-based fats. All these things are really health promoting. It's just that comes attached to weight in a way that's inappropriate, like, from an evidence base. And so there's two sides of that. Is one that people make these really positive changes to their diet, but because they don't lose weight, that value is not recognized. And then worst of all, they might be tricked into trying something else and something else and something else, rather than, they've done some really good health promoting things for themselves, but because of that weight attachment that we can't separate between health and weight, that happens. And the other thing that you said that's really bothers me, I find really troubling, is that, I wasn't worthy. I had to meet some moral standard in order to deserve basic health care. Like that's rough, huh?
That's just how I felt, and that's how so many people.
Yeah.
I mean, it's just, we know that obesity.
I think two things. I think we're recognizing it more, which is long overdue. I think there's recognition, as a part of it, there's recognition, and then there's acceptance, and then there's actually addressing the issue. And I think we're a long way from all of that. But I think there's that. I think when you talk about that sort of impression on your self-worth, we call that internalized stigma. So it's the idea of essentially the external stigma has been so pervasive for so long that people take that on board and start creating narratives around themselves that fit with that society narrative. And that's particularly devastating. And for my part, as someone that works in this area, those are some of the most rewarding interactions you can have. The problem is that I can have a conversation with someone around that and we can leave that room with a better understanding, but then of course I just throw them back into the outside world where all of that external pressure is as well. But those conversations like that, and that's, you asked me about what keeps me in this game, and that's something too that's particularly rewarding, is when if I can at least plant that seed that maybe this doesn't mean I'm a bad person. Maybe this is biology rather than choice. Maybe not, because that's the truth. The reality is we know 40 to 70% of what your weight ends up as and whether or not you have obesity is genetics, pure and simple genetics. We don't choose our genes. Then most of the rest, we talk about the environment stuff, but most of the environment stuff has most of its impact in the first 5 years of life, right? Fetal development, early childhood, all that sort of stuff. And so then we look at what people are doing now in their lives as adults, and it's very easy to forget that from a simple statistical point of view, so much of this, more than 90% of this, is set at a very young age, decades ago. And it's just that the manifestation of that in terms of body weight and all these sorts of things takes so long to kick in. And again, this is not new to obesity. It's not a way of obesity. It's the same with colon cancer. Your genetics is set and you're exposed to this environment and you might get some polyps. And if we don't get the polyps out, you're going to get a cancer. And so that doesn't mean that when we see you at, age 50 and you've got polyps, that this is a new disease that happened to you in adulthood. Well, it kind of is, but the precursors to this were set a long time ago. And likewise, we know that, having a high fiber diet and a few other things, do prevent against colon cancer a bit. But we don't go there and say, when you get colon cancer, and say, well, what's your fault? You haven't been eating enough fiber. What's wrong with you? And all of that negative stuff. No. And likewise, we don't treat the colon cancer with all the preventative stuff. We don't go say, well, you've got a colon cancer now. Let's really double down on that high fiber diet that prevents colon cancer. No, we don't do that. We say, right, the best treatment for colon cancer is I'm going to send you to a multidisciplinary team who are going to have a chemotherapy person there, a radiotherapy person there, a surgery person there, supportive care. They're probably going to have, palliative care physicians and dietitians, and even links into social worker and psychological support. We're going to put together the combination that best suits you, is likely to give you the best outcome, and then and if it doesn't work, we're not going to blame you. And that's what we do with sort of most of complex chronic disease. That's what we do. We do this very differently in most circumstances. And the thing is, when you actually do it that way, when you actually meet someone, sit down, figure out what's going to work best, and do that, it really works. It's really life-changing, and you guys, I'm sure, have experienced that. I mean, that's why you guys are doing what you guys are doing, right? Like, it really makes a massive difference. And I think that difference doesn't come because of the surgery. I mean, yes, the surgery is one intervention, but really it's the attitude of saying, well, no, let's just see this as a problem, not as a problem person, but as a person with a problem, and let's just figure out what the best way to get a good outcome from that is. And it works. I mean, it works for everything else. Why doesn't it work for surgery? And you have these conversations with, the more junior the doctors you have these conversations with, the quicker the penny drops. Because once you get in a rut, particularly if you've been working for a long time in this idea of diet and lifestyle first, and it's really about motivation and all this sort of rubbish that just doesn't pay out with any sort of medical evidence behind it. Once you've been in that reality for long enough, you're really stuck. And that was my experience early on. Is I didn't get it until I came to a clinic where we did this and sat down with patients and heard stories from them that I probably didn't have a right to hear at that point, because I hadn't done this well in the past. But because of that, you step into that clinic where the clinicians there that had gone before me had created a relationship of trust where people did feel they could speak truthfully about, rather than, I'm sure, when you went to see people when you were feeling unworthy, your story would have been very dressed up. You would have come in with things like, oh, I know I eat too much of this, I know I eat too much of that, rather than, this is my story, this is what's happening, this is what my experience is of this disease. Often it comes dressed up because people are so used to that stigmatized response and what they're going to get. And so when that's stripped away and you actually get to hear people's stories, suddenly you realize, oh, this is someone just like me with a different genetic load. This is not someone that's made bad choices. This is someone that's made all the same choices I would. And they're in a situation that is different to mine, but we can do something about that. You know, you can take a lot of the overlay off and just do good medicine. You know, it's
you know, when I was actually
oh wow. Let's clone you. Yeah, okay. Yeah. Yeah, well, yeah, just good medicine. Yeah, yeah,
like, what
yeah.
all
Well, and that's, I mean, that's why. Well, yeah, and that's why I think, you know, because I'll often, as I said, I can go on for hours about why I think fair and equitable access in the public system is important. But from a big picture point of view, almost all the training we do as doctors, nurses, allied health clinicians of all varieties, even hospital administrators, we come out of whatever university or course we've been involved in, and we come to a public hospital almost always, either during training, during that initial undergraduate course, or shortly afterwards. Often there's internship periods, etc. For all of these, you know, there's grad years for nursing, there's internships for radiographers and physiotherapists, and all the rest of it. And that all happens in the public sector, mostly. Like, I know there are some private sector hospitals that do a bit of training, but the vast majority of it happens in the public sector. And so when we don't treat where we train, that's a problem. I'm a general surgeon, I'm an upper GI surgeon, I do esophagus and stomach and bariatric surgery and general surgery. But I can still have a good idea of what a hip replacement is and who should be referred to an orthopedic surgeon about hip replacement. I can recognize heart failure and know the process of how we treat that, diabetes, etc., etc. All that has come about because I worked in centres where all of those things were treated on a regular basis. And so that perspective is just in your work automatically, in a way that reading about it can't really.
Yeah.
And the other thing too, like, let's be fair, there is so much in medicine. If you wanted to try and read up on everything and keep up to date on all areas of medicine, No, absolutely, unbelievably impossible. And you really rely on that network of experienced clinicians picking out what's important, what's not, and keeping you up to date. And so my interactions in this whole hospital with renal physicians and geriatricians and oncologists and all the like keep me up to date. And when obesity is off the table and all you know is diet and lifestyle, then you don't get kept up to date. And not only that, is you don't get the basic understanding and frameworks that people who specialize in obesity use, like the things that we employ. And so you end up with a generation after generation of well-trained, caring, intelligent individuals that are just missing that piece, that don't understand what normal obesity assessment workup looks like, and decision-making around treatments most or least likely to keep people alive looks like. And so that's, I think, where the public sector really comes in. Yes, we should be treating people, and I'm not putting aside the value of treating patients. That's important as well. But I think we also got to think about, in terms of obesity is not going away. And for the next 10, 20, 30 years, how do we have a set of clinicians that are ready and equipped and knowledgeable and practiced in treating it? It's got to be in the public sector. And that's the problem at the moment. 3% of Australian hospitals offer evidence-based obesity care. That's medications or surgery. And the rest are offering the same advice-based therapy, which is better delivered in the community. You know, your GP is going to do a better job of that. Your community dietitian, yeah, that whole system, you know, that needs to be given close to you so that you can keep coming back and back and have a relationship with someone in the community. We can't do that from a tertiary centre. So why do we try? Why do we just keep throwing out the advice that's better given in the community? Why aren't we stepping up and doing the specialised care that we should be providing? I don't know what modern medical school looks like in terms of that. It was certainly, you know, a very small part of my medical course. Because of the lack of awareness, it's seen as in a different light. And you sort of, the myths perpetuate because there's just no knowledge given to counteract those. And so, yeah, we see that certainly in dietetics. Again, you know, there's a group of dietitians out there that are very specialized in obesity. And when you talk to most of them, but you talk to most of them are self-trained. You know, they've done little courses here and there, but most of them have taken what they learnt in their degree, set a fair bit of it aside, and deliberately chased different knowledge. And they really are a breed amongst themselves. And they, you know, I work with a couple, particularly in the private practice I work in, and you know, the conversations in the hallway, it's just a constant feed of information. Like I earn more from these ladies than, about obesity, I can imagine, just in terms of practical, sensible approaches and advice. And I'm just constantly learning from these ladies. And when you pin it down, they just had to do it the hard way. Years of experience, and there's great network, actually. There's really cool network. Like, they're really out to help each other out and educate each other. And it's a really cool little network to see, until you realize just how small that network is in the face of the problem we're dealing with.